Stroke, ischemic versus hemorrhagic. Diagnosis, management, and time-critical decisions. A 67-year-old woman is brought to the emergency department by her husband. She suddenly couldn't speak 45 minutes ago, and her right arm dropped to her side. Her blood pressure is 185/100. What is happening, and what do you do in the next 60 minutes? Welcome to Medical Sciences Unfolded. Stroke is the second leading cause of death worldwide, and the leading cause of long-term disability. Every minute without treatment, approximately 1.9 million neurons die. The phrase is literal. Time is brain. First, let's establish the fundamental distinction. Ischemic stroke accounts for 87% of all strokes. It occurs when a thrombus or embolus occludes a cerebral artery, cutting off blood supply to the brain territory it performs. Hemorrhagic stroke accounts for 13% and occurs when a blood vessel ruptures, either into brain tissue itself, called intracerebral hemorrhage, or into the subarachnoid space, called subarachnoid hemorrhage. This distinction is critical because the treatment for ischemic stroke, thrombolytics and thrombectomy, would be catastrophic if given in hemorrhagic stroke, where the priority is controlling bleeding and reducing blood pressure. The two presentations can look identical clinically. A non-contrast CT head is the first and urgent investigation, performed to rule out hemorrhage before any treatment decision is made. Ischemic stroke has several subtypes by mechanism. Cardioembolic stroke, most commonly from atrial fibrillation, where clots form in the left atrial appendage and embolize to the brain, accounts for 20 to 25%. Large artery atherosclerotic stroke involves thrombosis at a plaque in the carotid or major cerebral artery. Small vessel lacunar stroke results from lipohyalinosis of deep penetrating arteries, classically in hypertensive patients, producing pure motor, pure sensory, or ataxic hemiparesis syndromes. Clinical presentation correlates precisely with the vessel involved. Middle cerebral artery stroke, the most common, produces contralateral face and arm weakness greater than leg, aphasia if dominant hemisphere is affected, and hemineglect if non-dominant. Posterior circulation strokes involving the basilar artery cause crossed findings, ipsilateral cranial nerve deficits with contralateral limb weakness, vertigo, dysphagia, and coma in severe cases.
The NIHSS, National Institutes of Health Stroke Scale, quantifies stroke severity from 0 to 42, assessing level of consciousness, gaze, vision, facial palsy, limb motor and sensory function, ataxia, language, and neglect. It guides treatment decisions and predicts prognosis. For ischemic stroke, the two pillars of acute treatment are IV thrombolysis and mechanical thrombectomy. IV alteplase, TPA, is given within 4.5 hours of symptom onset in eligible patients. It activates plasminogen to form plasmin, which dissolves the fibrin clot. The major contraindication is hemorrhage on CT, prior intracranial hemorrhage, recent surgery, and coagulopathy. Blood pressure must be below 185/110 before TPA is given. Mechanical thrombectomy, retrieving the clot with an endovascular stent retriever, is now the standard of care for large vessel occlusions up to 24 hours from onset in selected patients. The DAWN and DIFFUSE 3 trials extended the treatment window using perfusion imaging to identify salvageable brain tissue. In hemorrhagic stroke, management is the opposite. Blood pressure is lowered aggressively, targeting systolic below 140 mm mercury within 1 hour. Anticoagulants are reversed immediately. Neurosurgery is consulted for hematoma evacuation if there is cerebellar hemorrhage over 3 cm or herniation. Seizure prophylaxis and ICP management are critical. Subarachnoid hemorrhage, typically from a ruptured barrianeurysm, presents with the classic thunderclap headache, the worst headache of my life. CT sensitivity is 98% within 6 hours. Lumbar puncture showing xanthochromia confirms the diagnosis when CT is negative. Nimodipine, a calcium channel blocker, is given to prevent vasospasm, the leading cause of delayed neurological deterioration. Secondary prevention after ischemic stroke, antiplatelet therapy, with aspirin plus clopidogrel for 21 days in minor stroke, then aspirin alone long-term. Anticoagulation for cardioembolic stroke from atrial fibrillation. Statin therapy for all. Carotid endarterectomy or stenting for symptomatic carotid stenosis above 50 to 70%. Aggressive management of hypertension, the single greatest modifiable stroke risk factor. The woman in our case has an MCA stroke. The CT is clear, no hemorrhage. Her symptom onset was 45 minutes ago. She qualifies for TPA. The clock is running. Thank you for watching Medical Sciences Unfolded.